We are like,
Yes, proceed. Dr. Devashish.
Very good evening to all the EIZOC members from all over the nation. This is our 40th episode of the Ophthalmology Residence Teaching Series, or in short form ORTS, as we call it in our daily day-to-day activity. At the onset, I'd like to thank Dr. Ajit Babu Majji for mentoring the entire episode over the years together, as well as our chief coordinator, Dr. BNR Subudhi, and other coordinator, Dr. Sabyasachi Patnaik, to take care of this program over the years, episode after episode, year after year. I thank my office bearers, along with my president and my chairman scientific committee, for this webinar. May I welcome Dr. Ramesh Kekunaya, the HOD of the Pediatric and the Neuroophthalmology Unit of the LV Prasad Eye Institute in Hyderabad. I welcome our dynamic moderator, Dr. Anuradha Chandra from the Global Eye Institute. We have a young brand of panelists from the all over the Eastern Zone, Dr. Sandeep Sahu, Dr. Savita Devi, Dr. Nilotparna Deori, Dr. Randhir Kumar Jha, Dr. Tirthajit Maitra, and Dr. Batriti Shamplang Walag. We have 8 discussants from different states of the EIZOC, the Gen Z, if I may call them, and with everybody, let us initiate the program today. Over to you, Dr. Subudhi, sir.
Hello, good evening.
Hello, good evening.
Well, there's some echo is going on. May I request our president to give a few words? President, madam?
Yes, good evening, everyone, and a very happy new year also to all. So, on behalf of the IZOC, it gives me immense pleasure to welcome you all to this ORTS webinar, session 40. ORTS has become one of IZOC's most valued academic initiatives aimed at strengthening clinical thinking, updating knowledge, and encouraging interactive learning among residents and practicing ophthalmologists alike. I am truly happy to see the enthusiastic participation that we are going to have today, and we hope for that. So, this evening, we have a very important and clinical relevant topic: hereditary, nutritional, and toxic optic neuropathies. So, we are deeply honored to have Dr. Ramesh Kekunaya, HOD of Pediatric Ophthalmology and Neuro-Ophthalmology from LV Prasad Eye Institute, Hyderabad, as our distinguished speaker. His vast experience and academic contributions will make this session a very valuable one for all of us. I also extend my sincere appreciation to our mentor, always Dr. Ajit Babu, our moderator, Dr. Anuradha Chandra, the esteemed panelists and discussants, and especially the entire organizing team, especially the chief coordinator, Dr. BNR Subudi, my good friend, and also Dr. Sabyasachi Patnaik for the dedicated efforts in putting together this wonderful academic program. I encourage all participants to actively engage, ask questions, and make the most of the interactive discussion planned at the end of the session. I also thank Entot Pharma for their continued support towards academic excellence. With this, I formally welcome you all once again and look forward to a stimulating and enriching session. I think now we should start the session. So over to our Chairman Scientific Committee, Dr. Nitin Dhira.
Thank you, ma'am. Thank you, BNR, sir. Thank you, everyone. And sir used to be my teacher, Dr. Ramesh Kekunaya. And I still remember the days of residency when I was with sir. So none other can be better teacher than sir, this topic. And I feel that entire EIZOC and all the residents, those who are listening, they should be very blessed hearing sir about this topic and listening him. So without wasting much of time, I believe that we should start the program. Over to BNR sir.
Thank you, Dr. Nitin. So on behalf of ORTS program, I welcome you once again to all this our 40th episode of EIZOC ORTS 40, having the topic of hereditary, nutritional and toxic optic neuropathies with the speaker, Dr. Ramesh Kekunaya. So as usual, as has been told by President and the Secretary, we organize programs for the residents of EIZOC, also from all over the country also. So to educate certain topics which have been new topics and new speakers to introduce. And this time it's a wonderful topic, toxic neuropathies. And I must thank our EIZOC team, President, Secretary, and Chairman Scientific Committee, encouraging each and every episode we conduct for this program. And of course, a few words of praise for our mentor, Dr. Maji. Definitely, he's shaping our program day by day and improving the program day by day. Thank you, sir. Selecting the speakers and topics. And I must thank my co-coordinator, Dr. Sabasaj Patnaik, always with me, supporting me. And Dr. Ramesh Kekunaya, he will be introduced by our moderator today. I will be speaking about the moderator, Dr. Anuradha Chandra. She is a consultant ophthalmologist in Kolkata, specializing in pediatric ophthalmology and strabismus, cataracts and neuro-ophthalmology, and is currently assisted at the Global Eye Hospital and Spectra Eye Hospital. And today's panelist is already been told, young dynamic group, Dr. Sandeep Sahu is the professor of AIMS, Bhubaneswar, Dr. Savita Devi, Associate Professor, MKC Medical College, Berhampur, and Dr. Neelparna Deori, she is the Senior Consultant, Pediatric Ophthalmology at Strabismus, Arbor Whitey Eye Clinic, Guwahati, Assam. Dr. Randeep Kumar Jha, currently Professor of Ophthalmology, Darbhanga Medical College and Hospital, Darbhanga. Dr. Tirupjit Maitra, Phaco Surgeon and Medical Director Specialist, Narayan Netral Eye Hospital, Ranchi. And last but not the least, Dr. Bhatitri Shampilan Walang. She is in private practice partnership at Meraki Eye Care, Ceylon. And today's discussants from different medical colleges of our Eastern Zone, Dr. Rakesh Kumar Khandelwal from RIO Cuttack, Dr. Shreyas Gokhale, AIMS, Bhubaneswar, Dr. Ravi Prakash Singh from DMCS, Darbhanga, Dr. Sushil Kumar Sahu from High Tech Medical College, Rourkela, Dr. Pooja Chaudhary and Dr. Sara Gokhale from SN, Kolkata, Shankaracharya, Kolkata, Dr. Sakshi Nautiyal from Ruby Eye Hospital, and Dr. S.S. Priyadarshi from MKC Medical College. So I welcome all of you to this 40th session of our ORTS series. And I also welcome the viewers who are behind the screen. And let me thank once again all the EIZOC people joining with me for this program. And it's over to Dr. Anuradha to introduce the speaker and start the session. It's over to you, Dr. Anuradha.
Thank you, sir. It is an honor to introduce Dr. Ramesh Kekunaya. He needs no introduction. He is very famous and distinguished ophthalmologist. He is the head of the child eye care in LVPI, and he is also a network director of technology innovations. He has multiple articles in peer-reviewed journals, more than 185. He had done his pediatric ophthalmology and strabismus fellowship in UCLA, and currently he is the editor of the prestigious journals, including British Journal of Ophthalmology and BMJ. He has received many awards during the Achievement Award of AAO and multiple awards from APOS. He is the Executive Bureau Director of World Society for Pediatric Ophthalmology and Strabismus and Administrative Council member of International Strabismology Association. Over to you, sir. Thank you for joining us.
Thank you very much, indeed. So I would like to thank, first of all, Dr. Ajit Babu Maji for this invitation. Without this invitation, I will not be connected to the EIZOC for the second time. So I'm very thankful to Dr. Ajit Babu for this particular invitation. And also I'm very thankful to Dr. BNR Subudhi and the entire organization of EIZOC. Last time when I connected, I was speaking about myopia just 4 or 5 weeks ago. And I had this second privilege to connect because I've not traveled much on the East Zone. So this is an opportunity for me to kind of share our knowledge and see what can be done, and we can discuss some of this. So let me share my slides. I hope it will be visible in a minute. Yeah, it should come up. So I hope it is seen and I'm audible.
Yes, sir.
Let me start this topic. As I said before, it's a little bit long topic, but I will make and give a snippet of all of these three important topics, not only from patient care and also from residents' knowledge perspective. It's important. So I'll be talking about hereditary, toxic, and nutritional, and bit of its treatment, how we can practically manage in a high resource setting and also on the low resource setting. In between, I have the names of few: Rakesh, Shreyas, Ravi, Sushil, Pooja, Sarang, and Priyadarshini. Any one of you can answer. This is not an exam. This is basically knowledge sharing. More questions you ask, more you can take from this webinar. I don't want to complete my slides, but I would like to have this interactive. So these are my disclosures. None of these are related to this particular presentation. So everyone should know various shades of gray, that is optic atrophy. Because when you see an optic atrophy or a pale disc, there are differential diagnoses. Can you see that? Temporal pallor, asymmetrical pallor, diffuse pallor, disc pallor with gliotic changes, and it can be consecutive to something. When you see this kind of temporal pallor in the first picture, you see differential could be, it can be post-neuritic, it can be nutritional in our part of the world, it can be toxic, it can be hereditary. When you see asymmetric, nutritional and all these things will not be asymmetric. When you see this, especially with bitemporal hemianopia, you think about chiasmal compression. When you see this diffuse pallor on the background, can you see these gliotic changes and retinal changes? This could be post-vascular occlusion, either CRAO or ophthalmic artery, or it can be ischemic. Sometimes it's consecutive to retinal dystrophy as well. And when you see this disc pallor with gliotic changes, specifically around the disc, if you see some changes, that means there is a past increase in the elevated intracranial pressure. It can be IH, it can be even tumor. And the last thing I said, always look in the totality of the retina. Finally, the retina converges into optic nerve. You need to remember, when you see an optic atrophy, it can be consecutive. This is very important because patients with optic atrophy will not come to you with the diagnosis of hereditary, nutritional, or toxic, or compressive. You need to really derive it, which of these are there. That's why this is an introductory slide. I hope all the residents got it. Temporal, asymmetrical pallor, diffuse pallor, disc pallor with predominant peripapillary change, and then retinal. These are all cases we are seeing after a disc edema, right? And then you have this by birth, when there is a large cup with a large disc with inferior field of defect like this, that means it's a cerebral vascular accident or cortical visual impairment because of hypoglycemia. This is we see in children and also in adults. That's why I always ask history of prematurity and any kind of peripartal or postpartal insult. This is very, very important. This is the most important slide. This is an introduction. If there are any questions, I'll wait for 5 seconds. I can take that and then move forward. Okay. So let me cover up some of the hereditary. HON in short form is hereditary optic neuropathy. There are syndromic hereditary optic neuropathy and there are non-syndromic. If you see non-syndromic, it's the Leber hereditary optic neuropathy, dominant optic atrophy, we call typically OPA, X-linked, and OPA3, which typically has cataract, and OPA can also be recessive, that is 6-7. There are 8 types of dominant optic atrophy which is associated with OPA gene. This is very important. You have dominant and we have X-linked, we have recessive. This is in short. I don't want to go into the complete details. Typically, hereditary optic atrophy does not come by birth. They come to you typically at 15 years, 17 years, 18 years. Sometimes when they go into driving license, they find out that both eyes vision is less. That's where you pick them up. You don't pick them up in the pediatric or less than 10 years. They usually come to you around 18 or 20 years of age. These are some of the genetic mutations associated. Wolfram syndrome, also known as dead mort syndrome. Always remember, in a child with optic atrophy hereditary, think about, also ask about diabetes mellitus and diabetes insipidus. And then there are syndromic ones. These are very, very rare. Wolfram syndrome is not so rare in our part of the world because many of this optic atrophy, the endocrinologists, they don't know. They keep on treating them as diabetes mellitus. There is an opportunity for an ophthalmologist to give this input, probably diagnose the Didmot syndrome or Wolfram syndrome, which can also be associated with diabetes mellitus, diabetes insipidus, optic atrophy, and deafness. This is one of the studies. Dr. Bhatriti also is a part of this study. We looked at the etiology of clinical profile of childhood optic nerve atrophy in our center. This is way back in 2014. You can see most common is idiopathic and related to hypoxia. Half of those idiopathic, if you do genetic test, they will switch to hereditary. So we have underrepresentation of hereditary in this series. We are talking about 2014. Now we have a very good genetic service. Our diagnostic capability has become better in this hereditary optic atrophy. I would like to share one case. 19-year-old boy, diminution of vision for 5 years. He is on insulin for IDDM for 15 years. And he is having hearing difficulty in both ears since six years. Okay. And 2080 and 2000. Look at his optic now. RNFL is thin. MGCL, macular ganglion complex, you can see. And there is a diffuse optic atrophy in the presence of diabetes and insipidus. This is a form of hereditary optic neuropathy. It is syndromic. Not very difficult when you have this information in hand. Otherwise, you'll be thinking, okay, is this a compressive? All that. So this is a component of Wolfram syndrome. We have to do the pedigree analysis, as you can see here. We also did the genetic test. The Wolfram syndrome is associated with WFS1 gene. You can see the location is at exon 8, and terminal codon at 29. It's a homozygous, it's autosomal recessive disease. This is again 15-year-old girl, painless blurring of vision in both eyes since early childhood. Similar complaints in the brother, and they have horizontal nystagmus. If somebody has nystagmus with optic atrophy, you will think more in terms of hereditary rather than anything acquired due to chiasmal tumor or any kind of tumor. So you can see what type of field defect is it? Can anybody answer? Can I ask Rakesh what type of visual field defect you see? Shreyas? It's simple. It's already seen, right? Sarang, you want to answer? What is this visual field here? What you're seeing? Sorry.
Where is the field defect?
Look
Just
at,
see the location of the field
can you
defect.
see? Can you see the gray tone here? This is the threshold, this is the total, this is the pattern deviation.
Yeah.
What do you see in the pattern deviation? What you see here, for most of the neuro-ophthalmic fields, even if you see this gray tone, you can see this central and maybe a little bit of quadrant is involved. Probably we can say this is centrocecal. Both the blind spot as well as the central field loss is there. This is typically, as I said, this is a OPA1 mutation. Elder brother is affected, possibly it's a autosomal dominant, temporal pallor with the typical field defect. This is a no-brainer, most of the things. Even in a low resource setting without genetic test, we know it is one of the types of OPA mutation, or what do you call dominant optic atrophy, DOA. This is one of those. When should I suspect genetic etiology? This is very, very important from a clinician's point of view. Do I suspect in all patients hereditary? No. When there is temporal pallor, presence of nystagmus and strabismus, your thought process in terms of suspecting is more. When there is bilateral, symmetrical, irreversible, painless loss of vision, when there is family history, when somebody comes with vision loss due to optic atrophy and deafness, again you are thinking more in terms of hereditary. When the MRI is normal, sometimes they come to you, right, with 2 or 3 MRIs already done, not associated with retinal dystrophy. You know, always sometimes people confuse with retinal dystrophy with hereditary optic atrophy. Unless you have a complete picture of the retina, never make, because retinal dystrophy can lead to consecutive optic atrophy in some of the patients. You can see this typical temporal pallor. Progressive loss of vision, cecal or centrocecal field loss, and you have ruled out no toxic or nutrition. If you see in an elderly, you will think of toxic or nutritional first. And if you see in children, you will think more of genetic etiology. What investigation should I order? As all of us do, comprehensive evaluation is very, very, very important. And then simply looking at family members, just checking either the parents or the siblings can give you a lot. It's not that, hi-fi whole exome sequencing or optic atrophy profile, you have to do it in every patient. Simply with the investigations such as visual field, comprehensive evaluation, examination of the members of the family, you will get. And always ask for associated ocular and systemic history. In this case, I have typically written diabetes, and also deafness. Then I put phenotype in bold. That is more important than genotype. Genotype in optic atrophy is just to confirm. But you have a clinical suspicion, you can make it mostly by the comprehensive evaluation, field testing, and probably examination of family members. And do not forget to look at the face, any abnormality, because there are 100 causes for optic atrophy, like in this child. So I just want to ask probably who else, maybe Shreyas or Priyadarshini is there? What do you see in this face? Very typical face it is.
Any syndrome?
No? Any syndromic?
Shallow orbit.
What is that? Shallow orbits, absolutely right. It's a good finding. You are telling the finding, it's good, even more better. Yeah, what else you are seeing? When you see a shallow orbit with this kind of face, what? Yeah, you can't say it's Pfeiffer syndrome or Crozon syndrome. This is a typical craniosynostosis. They have a crowded orbit there. They can have a compression of the optic nerve, right? Very good. So this is one of the types of craniosynostosis. What do you see here? It's a spotter. What abnormality you see here? Ravi, you want to answer? Dr. Ravi Dayanand Medical College.
Sir, is it like hydrocephalus?
Yeah, you are right. It could be hydrocephalus. It is not really. In this patient, what happened is, can you see the suture there? It's almost like a boat skull, right? Completely horizontal. I have not given a front view. That's why you're saying it's hydrocephalus. It's a very good observation. This is not hydrocephalus. He had boat shaped. Again, one more type of. And when we did this, fundus photo shows optic atrophy, right? Can you see this around the optic disc? What you see there? This can be choroidal osteoma also. That's why in isolation, never look at this. And when you did the CT scan for this fundus photography picture, these two are different children, but the fundus photograph, the CT scan belongs to that patient. Patient had neurofibromatosis presenting as tram track appearance of the optic disc, the optic hole. Now we can see intraorbital portion. He had neurofibromatosis. Can you call this as hereditary? That's why I'm saying never forget the complete picture. Don't say that this is hereditary optic atrophy because there are telltale signs. Look at the diffuseness of the optic atrophy and also see the peripapillary area. We did all other tests, but this everybody has an access to fundus, right? This is very important. So do not forget face dysmorphism, examining the family members, ocular and systemic association, and don't just look at disc, look around. Retina is important. Sometimes they can have a corneal finding. It is important. Peripapillary area is important. And then face is important. Face can give you a lot of clue, especially in terms of hereditary one. You can see this is the glioma in another patient. You can see. So this is again one more patient. I always present cases so that you will get some take-home message. Painless drop in both eyes, right eye followed by left eye since 3 months. Okay. He takes mixed diet, no chronic medicine, no significant family history. Very, very poor vision in the right eye and little less in the left eye. This patient has a typical optic nerve atrophy. You can see both eyes. It's not really healthy there. They also got an MRI there. And we also have, he is 15-year-old. There is a sequential drop, okay? First right eye and then left eye. What do you think? Obviously, this you think as optic neuritis because hereditary optic atrophy will not come like that. Obviously, you will do MRI. MRI did not show anything. VEP did not show anything. The next step is to do a genetic test. In this particular case, a typical picture of Leber's optic atrophy, hereditary optic neuropathy. Typically, they will have one eye followed by the other eye. It typically sees like a optic neuritis. This is LHON. You can see the mutation. We did the mitome genome analysis, mitochondrial, and it showed there are three types typical mutations, which we will not go into the details. So this is also one of the type. There are DNA related optic atrophy. This is a mitochondrial related optic atrophy. That's why it's Leber hereditary optic neuropathy. So this is a typical series what we have seen in our setup. This is a study from South India. You can see we always have to diagnose because without genetics you can't see. You can see in this graph how it is variable in around the world, and it's very commonly seen and commonly misdiagnosed as optic neuritis. Again, it's one of the type of optic atrophy. Why this is important? Because these are the typical mutations. We have three types of mutations typically, but in India, we don't see any one of this. Why it is important? There is a treatment for this. This is called idibenonone. I hope many of you know about it. This is idibenonone. We have to give. There are 3-4 studies, RODOS trial, RODOS follow-up trial, everything has been done. I will not go into the details of this. Probably there is a rescue trial happened and also reverse trial also happened on the double-blinded randomized study for LHON. So they have seen significant improvement in these patients after starting idibenonone. So this is something you need to think about and keep it as a differential diagnosis. And there are some targeted therapy also coming to this kind of problem, especially hereditary optic atrophy. So in summary, genetic counseling and testing is important. Always correlate between phenotype and genotype for hereditary optic atrophy. Systemic association always. Drugs are there as per the reflect, reverse, and rescue. And always give them some rehabilitation. Some of them may need some kind of low vision aids. So send them and release them like finding a dory. It's like that. So any questions so far? This is about hereditary. Any questions from anyone? Pooja, Dr. Pooja, you have any questions?
Yes, sir.
Go ahead.
Sir, in which cases of LHON should we ideally go for the ibuprofen therapy, and in which cases do we need to go for the genetic therapy?
There is no genetic therapy available at this point of time, but idibenonone can be given in most of the patients who present acutely to you. Probably when I say acute, within 3 or 6 months of onset. Sometimes, if you are highly suspicious when they get the other eye, if you start, the prognosis is very, very good in them. But it's almost 20 tablets because you have to give 900 micrograms per day. It's very expensive. Some of them may not take it, but it's usually effective when you start it very early.
Thank you, sir.
Okay. So I think I'll go ahead with the toxic now. Can you see my slide?
Oh,
Yes.
Slides are visible, right? Yeah. So anyone, what are the various toxic agents which can cause toxic optic neuropathy? I think we will ask somebody who has not answered.
Methanol.
Dr. Rakesh. Yes. Sarang, go ahead.
The methanol, ethylene
Methanol.
glycol, digitalis, amiodarone.
Yes.
Ethambutol,
Very
alcohol,
good.
tobacco,
Excellent.
Linezolid, chloramphenicol,
Excellent.
chloroquine, hydroxychloroquine.
Linezolid. Very good.
even heavy
Absolutely
metals can
good.
cause
Yeah.
heavy metals.
Heavy metals can cause. So probably we'll not talk about everything, but this is the list you can see here. Most of you have said everything. In terms of drugs, chloramphenicol, linezolid, which is used for tuberculosis, sulfonamides, quinine, chloroquine, hydroxychloroquine, anti-tubercular medicines, you know, ethambutol is the most dangerous there. And in terms of anti-cancer drugs also, there are some of those which can cause. And I think some of you missed the sildenafil citrate and also semaglutide. I hope many of you know. It may not cause directly, it causes indirect toxicity and some of the antiretroviral. So this is in terms of drugs. Alcohol, you know, commercial alcohol also can cause methanol, and as you said, ethylene glycol. And then tobacco is the most dangerous. Carbon monoxide, you know, it can also cause. And then heavy metals like lead, mercury, and thallium. So this is in terms of a big list. We will not cover everything. We will cover one or two of those. Specifically, ethambutol is very, very specific and important from our country's point of view. One question, you know, how really this ethambutol acts? Anybody knows? This is here. It inhibits this enzyme called arabinosyl transferase. It leads to impaired arabinogalactan synthesis because this is a mycobacterium cell wall. It really penetrates there and kills the mycobacterium. Arabinosyl transferase is where it acts. But why it should cause toxicity? Can anybody answer? Why this particular drug, when it impairs this arabinogalactan synthesis, it can kill mycobacteria, but why it causes optic atrophy or toxic optic neuropathy? Anybody? Shreyas? So this
So it
particular
acts
one,
on the mitochondrial enzymes.
yes, excellent, very good. So this is the mechanism. It causes mitochondrial dysfunction because mitochondria almost simulates mycobacterium. So it causes mitochondrial dysfunction. It causes chelation, both copper and zinc, and it causes oxidative stress. Why mitochondria is such an important organ? Anybody knows? Why Leber's optic atrophy? Wherever there is mitochondria, why optic nerve is important, or vice versa? because a lot of energy is required to
Energy
see,
house. Energy storage house.
it's a, yes, exactly. So it really causes stress on that. When your energy source is depleted, you will get neuropathy. That's what happens. And you can see the linezolid and chloramphenicol and some of the aminoglycosides and some of the dominant optic atrophy causes cytoplasmic problem. You can see below ethanol and methanol, ethambutol and methanol, and ethambutol and LHON. They all have similarities. Now you know, even if it is one causes the other, there is some relationship. So it's not one mechanism. All of them lead to that attack on the energy storehouse. That's why you get this optic nerve injury. That's what happens. And you can see in this cartoon, you can see many of the mechanism, what it leads to. And what is the recommended dose of ethambutol? Anybody? Priyadarshini, are you there?
15 to 25 mg per kg.
How much? 15 to 25. Absolutely. You're absolutely right. That's the recommended by WHO. 15 to 25. That's why anybody comes to you with toxic optic neuropathy, you need to wait and look at the BMI. What is their weight? How much? Because Government of India gives the same dose for everybody. Because in that kit, it's the same dose is available. Whether it is too much for that person because of the weight, that we don't know, right? That's why it's very, very important to. So this is the recommended dose. Is there a universally accepted safe dose for ethambutol? Anybody? Shay is nodding or agreeing or not agreeing? Is not agreeing. Yeah, there is no accepted dose because of these factors. There is no accepted dose for ethambutol, which is safe. And how common it is, you know, if it is recommended, it's around 1 to 2.5%. If it is more than 25, as the dose increases, the chances of the toxicity is more. If a person is very lean, adults can be 40 kgs, they can be 50, they can be 70, they can be even reaching 100, right? So if you put the same dose for that person, 40 will have more chance of toxicity than the other. Of course, they should have a genetic predisposition. They should be having that ecosystem for this ethambutol to cause the toxicity. That is important. It's not one factor, but this is also one of the factors. There are some risk factors, dose and duration. More dose, more chance. More duration, more chance. Age more than 65 years, they have more risk. Renal pathology, if they cannot digest, if there is a renal involvement, that's why with the chronic kidney disease, you have to be extremely careful before you give this. Any form of hypertension, diabetes, malnutrition, smoking and alcohol is always there, and concomitant use of other neurotoxic drugs. If you do, they have high risk. And also genetic mutations. If they have a genetic mutation, which is more susceptible, then they will have it. What is the usual onset? On an average, it's between 2 to 5 months from the time of drug incision. We have seen less than 2 months also. You are getting some of the patients, and they can get it any time during the course of the disease. So this is one of the case. Can you see that very subtle pallor temporal? It came with the bilateral subacute painless progressive loss of central vision. And it can lead, the fundus can be normal. It can be hyperemic disc. You can have pallor. You can have peripapillary hemorrhage also in the later stage. So this is a typical, you know, they can have central or centrocecal. Many patients, they will come with bitemporal hemianopia. Why it happens? they can get something called chiasmitis because of ethambutol toxicity. And this, with the treatment, can completely reverse. And of course, the other OCT measurement, all that, it can help. And early optic nerve changes that could be missed on fundoscopic. Sometimes OCT really helps you in these patients, because this is somewhere, if you have OCT, picking up of chances of RNFL thinning is much more faster. You can also use OCT for prognosticating and also to follow. And MRI, as I said, it shows enhancement. Even the chiasmitis, it can show. It's not required in all patients, but if you get, it can show like an optic atrophy, optic neuritis kind of pictures. I would not say VEP is very, very essential. I would say even ERG, looking at the peak of the macular function, I don't think so. It's so important in these patients. How do you manage them? Screening with early detection. Whoever is on this DOTS or other things, screening is important. Stopping the offending drug is important. You have to give the cocktail of vitamins, particularly hydroxycobalamin or methylcobalamin, along with thiamine and pyridostigmine. It's a mainstay of treatment. Visual function may continue to deteriorate, but recovery is usually partial, and in some cases, it's a complete recovery we have seen with the simple vitamin B12 injection and stopping the ethambutol. Stopping the offending drug is the most important. And as I said earlier, alcohol and tobacco smoking, all that has to stop. Some people say that there is some role. Some of the institutes have started giving them idibenone, but still I would say the mainstay is this kind of vitamin is the most important thing. This is the follow-up protocol, what we really do in our institute. Standard dose 1 to 3 months, always rule out the risk factors, and then come for monthly. If they have risk factors, call them every monthly. Otherwise, 1 to 3 months. This is one more case, blurring of vision since 10 days, 2200, 2160. Many of these patients get cataract surgery, and then they are sent, pallor, vision not improving. Lens is removed, but the vision is not improving. So in this age group, we have to be particularly careful. Ask about the history, what is happening, because many people corroborate this vision with the cataract and remove the cataract, and actual problem you come to know after removing the cataract. So, sometimes the pallor can be very, very subtle. It's the history and the visual acuity and the color vision and other things really helps them to really look into. Always ask about other causes, because never jump into only toxic optic neuropathy. Look for other things. This patient did not have any of this, no trauma, no similar complaints in the family, no pain on eye movements, because you still have to come to a diagnosis. And diagnosis of optic atrophy never complete without asking for toxic medication. In these patients, it's anti-tubercular medication or on antiretroviral therapy. So obviously visual field you will get in all of these patients, and then OCT really helps in prognosticating and also following up. So both eyes likely optic neuropathy, this particular case, and if ATT is required, avoid ethambutol. This is something very, very important to check with our pulmonologist. You can see this mild temporal pallor, and visual field really helps most of these patients, because Even if you don't see that pallor, if you see this central scotoma, this is very, very diagnostic with the history of toxic medication. He discontinued, he improved to 2040 with the neurovitamins. Anybody knows the dosage of vitamins? Any one of the 8 heroes and sheroes, not only heroes? Sakshi, Rakesh is speaking. You are muted, Rakesh. You are unable to unmute. Yeah.
Sir, thiamine is given. It is given like 100 milligram twice daily, and folate it is given like 1 milligram daily.
Okay, that is a homeopathic dosage what you are giving. When you see a toxic optic neuropathy, this is the recommended dosage. It can vary from institute to institute. This is the recommended dosage. Injection intramuscular on alternate days, 1,500 micrograms of cobalamin for a month. That means 15 injections in that month. Same once on Sundays for the next 20 weeks. After you finish it 1 month, continue for 20 weeks. And it should be supplemented by your, you are saying about pyridoxine and other things. Usually we give Neurobion Alpha D. We don't have any financial interest for the 20 weeks. So your treatment really goes long way. And when you give this 15 injection, we see a significant improvement. Like in our medical college, we used to give these injections during our posting. First, the second MBBS posting was to give injection. It's a simple, very cheap drug, but highly, highly effective. I hope it is clear to all of you about ethambutol. This is very, very important. It's a public health problem. Every one of the residents must know. Every one of you should work with the physician. And it's a combined effort with which we can give, we can stop, we can provide treatment for these patients. So can we prevent ethambutol-induced optic neuropathy? Yes, there is a tertiary level, secondary level, and primary level. Awareness is very, very, very important. You all should play an important role, because stop immediately, provide alternate drugs and rehabilitation, early detection at the baseline assessment, because regular monitoring is important. And the primary thing is appropriate dosing. This is something you need to educate all the physicians and whoever is working, and identifying the high risk people. It's extremely important. So this is in short, how do you really manage? Give a lower dose of 15 mg per body weight. Renal function test, if you do it, and adjust the dose. These are all things we can do to prevent this ethambutol toxicity. Methanol, it's a dangerous one. A lot of sources are there for the patients. It used to be, COVID time, people used to drink, right? They used to drink like anything. They have just had that sterilizer. They used to drink and come, because that was a source. So paint, varnishes, perfumes, everywhere it is there. And it can be through inhalation. Some people have a habit of inhaling petrol and things like that. So it can cause a hazardous effect. And as you can see, it really affects on the ADH and ALDH in terms of forming the formic acid. And this is the final product, which is really toxic to the optic nerve. Again, optic nerve needs a lot of energy. That's why it's mitochondrial dependent. It can lead to even end organ failure. Many of the kidney functions, many of the renal Along with blindness, they can cause many things. As you can see, headache, they will come with nausea, vomiting, altered mental status, because it's an acute poisoning. Most of the time when they come, it's they can be in Kussmaul respiration, or they can have hypo or hypertension. They can be even coma and death. From ocular point of view, optic neuropathy leads the problem, and they can have CRAO and other retinopathy also. With the history only, you can make out the diagnosis, and you need to jump into acute management for this patient. Putamen, hyperintense and hypointense lesions you can typically see on MRI. Again, not a must if you take a good history for these patients. And it's immediate first aid treatment you need to do. One of the thing is hemodynamic stability is very, very important. If required dialysis, they will develop something called formic acid is there. So metabolic acidosis with bicarbonate. And this is immediately we have to start for these kind of patients. So this is where methanol poisoning, and this is the estimation of lethal exposure of this representative methanol symptoms in this is the published paper. What it says, how much is the most important dosage for them. And again, it leads to mitochondrial hypoxia, leads to ATP depletion, exoplasmic flow arrest. All these things happens. With that, optic nerve edema and visual loss. Usually, they will come with optic disc edema, and very, very acute management is required. So intravenous methylprednisolone is something given in a very high dose, and erythropoietin also is known to help in this situation if you have it. And you have to give supplement of vitamin B1 also needs to be given. And prognosis is not so great in this. As you can see in this publication, 50 patients were there. And you can see they also have putaminal necrosis. This is very, very typical of these patients. And visual field defects can be central to isolated central or paracentral scotoma. And you can see the visual acuity can be from hand motions, and they can also have 20/25. Better vision they come with the acute management, so that you can throw away the methanol faster from the body. They will become better. That's why acute management. Ethambutol is not so acute. Methanol poisoning is very, very acute. Linezolid, I will skip through very fast. This is also given in multi-resistant tuberculosis, MDR tuberculosis. It causes action on the ribosomal activity. That's what it does. It's a different mechanism than ethambutol. So it can cause papillomacular bundle damage. Again, more risk of systemic disease like renal failure, lactic acidosis. They have more chance of linezolid toxicity. Again, it's duration and dose dependent. And it's usually well tolerated if used within a period of 28 days. And as usual, alcohol and other nutritional status increases the risk. And this is the, how much dose it causes these problems. You can see 600 mg QD and BD. There is a significant difference between the two groups. And if they have anemia and other things, they have more chances. So how do you do? Again, stop it. Advise vitamin supplements. And in these patients, probably giving steroids really helps, not in patients with ethambutol toxicity. So they also improve if it is identified at an early stage. And this is a case report. It shows the vanishing of visual field defect. This is the new drug, semaglutide. I'll just say two sentences about it. Many people, why it is used? This is used to reduce the obesity and in terms of even diabetes. So when you lose weight, it can cause perfusion pressure difference of the optic nerve. And in fact, it can cause, similar to sildenafil citrate kind of picture, it can cause ischemic optic neuropathy. Even though there is a association, whether it is causal or casual, we don't know. But there is a slight risk with using semaglutide with the patients for this. So they have these publications are there. 1 weekly semaglutide doubles the 5-year risk. It's not immediate. 5-year risk, it doubles. They should have comorbidity like, disc at risk and things like that. Then they have more chances. So whether everybody gets, it's not true. It's like topiramate. Topiramate can cause angle closure glaucoma, right? Everybody gets angle closure? Not really. So there is a risk of semaglutide, but probably you need to watch out for ischemic optic nerve. That's why it's an indirect toxicity. So they can cause these abnormalities. So in toxic, just remember it can be acute, subacute, or chronic, usually bilateral with the simultaneous onset. And there is an insidious nature of vision loss. Visual fields are central or centrocecal. Very rarely it can be bitemporal. And always there is a history of drug use in this patient. And this is a kind of very, very busy kind of optic neuropathy slide. You can quickly take a screenshot, go back, analyze, synthesis, and then absorb, because this is an important slide, not only for toxic, but how do you really take care of optic neuropathy? Because patient does not come with, I have nutritional deficiency. You have to reach there. So this is one of the beautiful slide. If you want to take a screenshot, you could take. Last part, probably 2-3 slides. It's 9:06. And then we can have some questions and answers if there is some time. Nutritional can be, again, it's not only B12, it can be from folate, thiamine, and copper deficiency. You can see in this really on the table what is normal, what is pathological, right? And then what are the symptoms? Typically, they will come with progressive bilateral symmetrical visual impairment. Usually, it affects the adults nutritional, unless some of the children, they eat. There are children who eat only junk food. Like they thrive on finger chips, potato wafers. If they are having that kind of habit, they can develop lots. And when I was doing fellowship in US, a lot of children used to come with nutritional optic neuropathy. They don't eat anything. Also, they have some malabsorption syndrome. It can be. And in adults, it can be purely, if you are vegetarian, you can have it. And as you can see in the picture, if you have any bariatric surgery, either band or something, then you can have it. And vegan diet is catching up, right? Vegan, many people are turning to vegan. If you have these things, chances of nutritional optic neuropathy is very, very high. How do they present to you? Again, it really looks like toxic or hereditary, but in an older version. So they will have typical, as you can see here, this is from one of the publication. This patient had nutritional optic neuropathy due to pernicious anemia, which is nothing but the picture A is optic atrophy, you can see. And picture B, I think you would have heard Wernicke-Korsakoff encephalopathy. Again, they will have other symptoms. They may not come to you as an ophthalmologist. They may come to a neurologist, but they come with disc edema. So Wernicke-Korsakoff encephalopathy with an edema, with the poor vision, you need to think of thiamine deficiency. Very rare. Vitamin B12 is more common than thiamine in our practice. But when you combine with the physician and neurologist, you might see that also. What is the treatment for nutritional, especially vitamin B12? I said there we have to give alternate for a month, that is 15 injection. Here you give intramuscular twice weekly, either Monday and Thursday you can select for 12 weeks. Sometimes they can have borderline, you can even give them oral. Always add folic acid 5 mg OD for 3 months. With this, we have seen some of the patients reversing, they are getting their vision back. Again, do not do cataract surgery in this patient. They may not even improve. Do the thorough optic nerve examination. I think I'll stop here. Thank you very much for your kind attention. I'm very happy to take if there are any questions. And in fact, any other suggestions from the esteemed faculty, if you have seen any cases or any comments, are welcome.
So do we need to consider isoniazid also in case of antitubercular treatment?
Yes, we have to consider, but we have seen some of the patients with that also developing some kind of toxicity, but it's not very common compared to ethambutol. Rare. I would not consider in my routine clinical practice.
Sir, I have a comment to make, sir.
Yes, please go ahead.
Sir, actually today that ethambutol optic neuropathy, sir, you talked about chiasmitis. This is not talked about in most cases. So I had a patient who had ethambutol toxicity. He was stopped on medication. For a few weeks he was deteriorating. So I got two fields, and in the second field he came with that bitemporal hemianopia, and now I understand it was a chiasmitis. He had received Vislone for that. So Vislone, does it reduce the inflammation and so the patient improves temporarily?
Yes and no. Nothing really wrong in giving steroids.
Okay,
But in my experience, what I have seen a beautiful improvement is with the simple vitamin injections.
okay, sir. He was receiving
But I know many of the institutes are practicing a cocktail treatment,
Yeah.
steroid, vitamin B12, and adiminone. But personally, I feel what our physician, I gave you the prescription, how much you have to give. That works wonderfully because many people say that nothing can be done. You have lost your vision. I've seen, I'm not saying 100% of the patients will get back their vision, but in my opinion, majority of the patients, if they do not have any risk factors, they get back most of their vision when you start this. You can see a wonderful improvement when they come after 4 weeks or 6 weeks. To answer your question, okay, if it is steroid is completely contraindicated, not really.
Okay. Because he was on ATD for non-pulmonary tuberculosis. And giving steroid would be like putting him in danger, what I thought. That is why I
That's a very valid point, because when they are in this kind of illness, they may have other risk factors, like as you said, pulmonary. They can have kidney issues. They can
yes,
have diabetes. They may be on dialysis sometimes.
yes,
So why to kind of, and many people have a doubt. Oh, I'm seeing a chiasmitis. Is it optic neuritis? It is a MOG optic neuritis. People can think. That's why MRI may not be mandatory, but if you do it, you can rule out other causes as well, because they may have other pathologies, right? That
yes.
way. So chiasmitis is a very, very known situation in optic neuritis due to ethambutol.
Thank you, sir.
And not only that, in tuberculosis, you need to rule out any active lesions in the body. That recently we
Yes.
have done
Yeah.
one PET scan, and we found the patient who had 9 months ATT still having a activity in the spleen. That was detected on PET scan.
Okay. Yeah. I think that's a very valid point. To that person, if you are injecting steroid, it may be
Can be
counterproductive
dangerous.
in the whole situation. Yeah. Yeah. In the setting of tuberculosis, I am not on to start steroids. But that's why I said do comprehensive evaluation, ask the history, diagnosis is there on the face of the patient. It's not that you have to do many high five
Yes.
investigations, it's there. Okay, I think if there are no questions.
Because the moderator is silent means there are no questions.
No,
Okay.
Pooja, would you like to have some questions?
Can you have some comments
Hi,
to the panelists? Yeah.
hi Ramesh. This is Dr. Randhir.
Hello.
Hello, Dr. Randir.
Yeah, nice. It was such a nice elaboration of the topic. I just want to make
Thank you.
add to the topic of methanol toxicity. Since we are in a dry state in Bihar, we get to see a lot of methanol toxicity. What we have seen temporary that after a few months or a year, you get to see those patients having, to some sort of near total or total cup. And many a time, if you don't get a history and if you don't know the actual situation, you start treating them as a glaucoma. So if you are getting a normal IOP and very low vision, and if you can temporarily correlate that the patient had methanol toxicity, you can consider it, I mean, non-glaucomatous. This is what I would like to add on to this.
Yeah, I think it's a very, very important point, because people will be investigating for glaucoma, what happened, normal tension, all that. I think it's a very valid point. Thank you, Dr. Randir. Yeah.
Dr. Nilutparna, would you like to add some comments?
Actually, sir has covered it so well. I was just listening to what he was saying. I was just recapitulating everything that's in the book. I do not have much to say, but I had one patient from Hyderabad actually. We had done the genetic testing for him, and he was OPA1 positive. And we tested his sibling and his mother also. He went ahead with all this idibinon therapy, but he was asking something about Savir therapy, that micropulse therapy. Ramesh sir, would you like to comment something on that?
I'm not really sure, because if it is OPA1, chances of improving is very minimal with the idibinon.
Yes, sir.
Because it is usually effective in Leber's hereditary optic neuropathy, not in OPA1 related. That's why when you do a genetic test, these are the differentiators. They asked me, why do you have to go through the genetic test? I said, if you get this, we know what are the risks and other things. And also, one is partially medically treatable, one is not. So I would not really treat the other OPA one with anything other than your protective, because any optic atrophy, you need to say avoid toxic agents like tobacco, alcohol,
Yes.
streptomycin, all these drugs. You need to give a list of drugs.
Yes.
Avoid this. This
Okay.
is something including ethambutol, all these things.
Yes.
So these are the some of the simple things what we can do as physicians, but I would not really start any active treatment in OPA1 mutation.
Yeah. Okay. And along with that, we also suggested him for low vision aid also, because
Yes,
he was on duty.
absolutely.
So that is one thing that we added for him.
Yeah.
Okay.
Low
Yeah.
vision aids, I will always encourage. They need, they are in that typical high school or college going.
Yes.
They need some kind of approach magnification may not really help them. They may need some instruments also, depending upon the situation.
Yes, sir. Thank you. Thank you so much,
Where,
sir.
yeah, very important part of comprehensive management of hereditary optic atrophy. Absolutely.
Dr. Nitin, Dr. Priyanka, would you like to add something?
Dr. Ramesh, I have a question. Sometimes you come and a lot of people take methanol in the spurious alcohol.
Yes,
Mass,
sir.
maybe 20, 30 people at a time. In those cases, what to do? So let us say you get a lot of people simultaneously. How do you manage these people?
We unfortunately didn't get that kind of situation, at least in the last 20 years where I was there. But I don't know, you should be able to tell us your experience, because the problem is, setting up that acute management if they need dialysis and other things becomes very difficult. Other than that, optic atrophy, optic neuropathy point of view, it's simple, because their problem is not vision loss. When they have this acute poisoning, the problem is more of the general management becomes very important along with this. So I personally do not have a mass, huge tragedy kind of situation. Personally not managed, because most of these patients, they go to a government college or a
Yeah.
government institution. They have never come that way. But I have managed many acute cases as a single or two people coming or things like that. Yeah.
Yeah, that's true. True. They go to the government college. They don't go to LVPS.
No, sir. No, no. Yeah. Because of
I
many
know.
factors.
Yeah.
Yeah.
So, Dr. Shreyas, Dr. Sarang, do you have questions?
No question. They understood well, I think.
Yeah. I think salient features you need to remember
Yeah.
when to suspect hereditary, most important drugs, and ethambutol toxicity. Most of the times it's within the doctor's
So,
purview to
doesn't
treat
it
them
is
and also to
okay.
prevent them. And the last thing is the nutritional aspect. Again, before doing cataract surgery, because many times
Yeah.
I've seen patients are sent because after cataract surgery, vision is not improving. So do a thorough evaluation. It's not that every cataract tomorrow you have to evaluate for toxic, but there are on the face history and things like that. You need to take them.
Dr. Sandeep, would you like to comment?
Good evening, sir. Sir, as Subhiti sir asked about this methanol poisoning. So the golden hour is actually, sir, from my resident period, I am just remembering all this thing. The golden hour is 2 hours, first 2 hours. So if there will be gastric lavage in the first 2 hours, so there is some very good improvement will be there. Okay. So if there will be it's latent, then if it is better after 2 hours, there is no important of any gastric lavage in that. And the other management are almost same. And one thing is sir already elaborate everything. But thing is that how we'll evaluate all these things. means when in our part of world, mainly nutritional, we are seeing all the temporal pallors are coming to us, but we are not overlooking all these things. So what will the set of evaluation we should do all these things in this? And another thing,
simple
sir.
way I would say, history of diet and any drugs and the duration, and I will do the optic nerve evaluation and visual feeds. These 5 things will give you some clue where it is going. If there is a chiasmal compression due to something, you will get MRI. If you know that the person is vegetarian and having some malabsorption, they had some bariatric surgery, I will go into more of a nutritional. But if they are typically giving, I've taken a ATT for the last 6 months, I will go in that direction. But having said that, if there is no toxic, it can be between nutritional mostly. I will get a simple serum B12 and folic acid level.
Now
it's the simplest thing you
blood
can
tests
get
are there for evaluating
Yes.
different vitamin levels.
Correct. You
Another
can get
things
it.
are
So these are the 5 things I would say in brief. How do you go about temporal pallor in a cataract patient? History as well as examination. Yeah, go ahead. You are asking second question.
No, it's not a second question, sir. So actually, sir, toxic, mainly in toxic, the earliest sign, I think it is the color, mainly yellow, blue, and red one. So we should add
This
the color
chromatopsia.
also,
Yeah.
color blindness testing also in our first things. And and when this TB patients are coming, first, no doubt it's a ethambutol toxicity first will think, but if after stopping or if after reducing this 25 to 15 or like that, so if it is not means improving, so we should think about isoniazid also. So these are things I think add in this.
This is something we were discussing at the primary level. When they treat them, disc chromatopsia is a very good test to screen them.
Yes.
You are
Not
giving
many
it a
people are
primary
doing,
PTC center.
Unfortunately, not many ophthalmologists are not doing this.
Correct. And when they come to ophthalmologist, they are on the other side. Already it's there. You can try this, reducing the dose, all that at the primary level. But when they come to you, they are 40 kg, they have renal pathology, people are pumping 35 mg per kg or all that. So it needs, little bit of thinking, and it's important. You're right, absolutely right that disc chromatopsia as well as hyperemic disc is the first sign what
early
you will
stage.
see.
Early stage is hyperemic disc, not the pallor. Second,
yes,
if it is started within 1 month or 2 months, it is mostly ethambutol, not isoniazid.
Correct. Yeah, when it is not improving with this your modality, in spite of your treatment, then that is also another possibility, which is a rare, but it can happen in some of the patients.
Over to BNR, I think.
Thank you.
If there are no questions, we'll go for the Thanksgiving ceremony. So I must thank Dr. Ramesh, really wonderful presentation, a very short and beautiful clinical tips for all these pathologies. Thank you very much for joining with us. And again, we look forward to meet you once again in the future.
Yes,
thank you. Yeah, thank you all my EIZOC team, Dr. Devasis, Dr. Jennifer Madam, and Nitin for your contribution to the program. And of course, Dr. Anuradha needs really commendation for their moderation. And all the panelists, they've given their comments. Thank you, the postgraduates. No doubt some of you have already participated and asked questions, but some people remain silent. Silence says that you understood everything. We hope so. And last but not the least, our mentor, Dr. Ajit Babu. So thank you very much. Look forward to again next month one more topic on ORTS and neuroophthalmology. Thank you very much. Good night.
Thank you, sir. Good night.
Thank you, Ramesh.
Thank you. Good night. Thank you, sir.
Good night.
Thank you.
Thank you.
Thank you, everyone.
Good night.
Good night.
Good night, everybody.